Okay, rolling right along. So our next speaker, I would like to introduce Shilpa Gajarawala, board certified physician assistant at Mayo Clinic. She has 25 years of experience in her work, and I mean, there's really not enough I can say about Shilpa. We started the EDS clinic at Mayo Clinic. She came in from the gynecology practice, new to Ehlers-Danlos Syndrome, and took it in stride and has done phenomenal work. She said early on that she was not going to do any public speaking, but I learned very quickly that she has exceeded my expectations and hopes of what she could do in sharing knowledge in a public forum. So I'm very grateful that she is here today. She is an assistant professor of obstetrics and gynecology, soon to be an associate professor. And she's actively involved in teaching in multidisciplinary care at Mayo Clinic. Her work includes supporting patients in women's health in Ehlers-Danlos Syndrome clinics and a focus on patient-centered care, education, and innovative treatment approaches. So please welcome Shilpa Gajarawala.
Just get set up here a little bit. All right, so welcome. Again, just a little bit, I need my speaker notes, so I have really no short-term memory left. And this is version 16 of my talk. So I really struggled with this talk because I'm very passionate about EDS and female healthcare. And so where do I draw the line? What do I include? What do I not include? So no, I'm good. I'm good. Sure? Yeah. I won't walk around. So version 15 had 90 slides. Today's version has 30, and yet I'm going to still have to talk double speed. Now, how many of you here watch Netflix? How many of you watch Netflix at double speed? Okay. All right, so that's going to be the speed of my talk today. So, okay. All right, I have no financial disclosures, no conflicts of interest. I have a fear of public speaking. That's my only disclosure. And the study that I'm going to talk about did have some funding sources, and craziness in deleting 60 of my slides. I deleted the slide that tells you about our study. So I'm going to be giving you some information about it as we go. The study has not been published, so if you would just please honor our request not to copy or photograph any of the information that has data without permission. So I have some lofty goals today in short time. So again, I'm going to talk a little bit faster, but I want to explain why gynecologic health is essential in females with hEDS and HSD. And maybe just to make it a little bit easier on my vocal cords, I'm going to refer to both, unless there's a difference that I'm talking about, as EDS. I'm going to describe how hormones affect connective tissue and EDS symptoms. I'm going to discuss gynecologic, sexual, and reproductive health differences between hEDS, HSD, and a control group from our study. And I want to also recognize some unique pregnancy risks that are associated with EDS. Now, time allowing, I would also like to outline some multidisciplinary care across the reproductive lifespan. So, the big question in the room is, why is it so important to recognize female health when it comes to EDS? Well, about a month ago, at the invitation of Dr. Bloom, I had the opportunity to speak at their symposium on female health, and my focus there was really about bias and barriers. And today I'm going to kind of pivot a little bit, and we're going to talk more about the biology. So, elephant in the room, who gets more affected by EDS? Thank you very much. And I think I don't need to say any more, right? So now the problem that comes up is a lot of symptoms that we experience are treated in isolation. And what does that lead to? Fractured care, multiple visits to specialists, subspecialists, referral back, PCP that says, I want to help you, but I just don't know what to do. So if you're having pelvic pain, you may see gynecology, dysautonomia symptoms, cardiology, joint symptoms, rheumatology, and yet nobody's really giving you clear answers unless you're very fortunate to have some really well-in-tuned providers. What EDS then does is it provides a unifying framework. It connects the dots. So, and when you connect the dots, you have a better perception, a better view, a better focus on how to provide the care, the management, the guidance, and the referrals if needed. So, making the connections. Connective tissue fragility affects pelvic support, fascia, vascular integrity. If I was to ask you to name one part of the body that does not involve connective tissue, anybody? Good. Okay. So now, what you may not know or be aware of is the pelvic organs are supported by ligaments. What are ligaments made of? Connective tissue, right? So no surprise there that we suffer quite a bit in that area. And I'm going to say this, I said it at a previous lecture, but from a young age, we are taught to ignore the pelvic area. How many of you remember the thing about how you learned anatomy as a child when you said head, shoulder, knees, and toes? There's no pelvis involved there, right? So now, connective tissue is hormonally responsive. So it's a phenotypic modifier. And I'm going to need my notes for this section. So let me catch up here. So what's key is that the hormones are not causing the EDS, but instead they're acting as phenotypic modifiers. So estrogen, progesterone, and relaxin directly influence collagen. They directly influence the tissues. They affect collagen metabolism. They affect extracellular matrix turnover. So our tissues are already vulnerable when we have a connective tissue disorder. And what then hormones do, in a sense, is they exaggerate that effect in us. So let's focus a little bit on estrogen. Estrogen is kind of unique in that it is dose dependent. So what that means is that at low doses, it actually stimulates collagen synthesis and cross-linking, and tensile strength is increased or improved. Now, what happens at higher doses is the opposite. So the net effect then is you have weaker tissue and you don't have that tensile strength. You don't have the rebound that you would want. So, and think about it, menstrual cycle, high estrogen states. When are they? Ovulation. Another would be pregnancy. So no surprise there why we have some clustering of symptoms around high estrogen states and low estrogen states. So now it's interesting. Research has demonstrated that tendon collagen synthesis rates are lower in females than males. And that in high estrogen levels, that compromises tissue integrity, and the biologic difference that we see between males and females is very easily explained to injury and pain when you look at the hormones. In males, for instance, tendon collagen synthesis increases robustly when you stress the tissue or load-bearing exercises. In females, especially during high estrogen states, estrogen attenuates the collagen synthesis response to mechanical strain. So I wonder why my husband working out, he's doing great. He's got that lean muscle mass, he's building muscle fast, and here I am still struggling. Worse during times of high estrogen too. So what that means basically is that female tendons show reduced adaptive loading and remodeling to exercise, and it's less effective repair from any damage with a lower net accumulation of load-bearing collagen over time. Now, progesterone is another story too. So this is where things get a wee bit interesting. Progesterone is tissue dependent. So there's a lot of low pathophysiology here, so I'm not going to go deep into that, but the effects of progesterone vary on the tissue. So for instance, cervical tissue, pelvic floor ligaments. Progesterone increases softness. You're getting a decreased collagen. So you're going to have laxity. You're going to have, less chance of rebound back to where you should be. Hence prolapse, right? If you think about it, when the pelvic organs tend to drop. Why do I never hear about male organs dropping? I don't know. So now you also need the progesterone effect, say in the cervix for pregnancy and delivery, right? So that's a key hormone during pregnancy. Now, interesting, but in joints, for instance, it's the opposite. We're going to see some benefit from the progesterone. So keep that in mind. And that's why I say it's tissue dependent. So now relaxin. This is the loosey-goosey hormone. It literally does what it says, relaxes things. It increases collagen remodeling and degradation. It prepares the pelvis for delivery, and it allows you to grow with your pregnancy. What happens though is that it also means that you're going to have some more joint issues. Anybody here been pregnant, had increasing joint symptoms during pregnancy? Yeah, subluxations. Sorry. So the bottom line basically is that relaxin is essential for normal delivery, but in EDS patients, it amplifies the existing connective tissue laxity leading to significant musculoskeletal issues and possible complications during pregnancy and delivery. It doesn't cause EDS, but it does, magnify the symptoms. Now, the other important thing with relaxin is its effects do not end with delivery of the baby. It continues postpartum, and that explains a lot of why we have continued symptoms, continued subluxations, and we just kind of don't seem to rebound as fast as we should. So now I'm going to focus a little bit more on menstrual disorders and EDS because that is me during my PMS part of the cycle. So our study findings show that there was no significant difference in cycle length or flow. And our study really looked across the board at sexual changes, sexual differences, basically menstrual cycle changes, anything related to gynecology and obstetrics we kind of looked at in this study. So teasing that out here, pain and systemic complications were, however, the distinguishing factor. So this, of course, correlates with the hormonal fluctuation, right? When you start your menses, what's going on? You literally have the lowest amount of estrogen and progesterone. As you restart, day one is the first day you bleed, and then your hormones start to kind of rise. Estrogen takes the lead and progesterone follows, and there's a bit of a negative feedback loop that I'm not going to get into. But of our study, dysmenorrhea, which is pain with intercourse, HEDS patients had reported as 62%, HSD patients reported 57%, the controls were 48%. So that's a pretty significant difference. You're saying, well, what's going on here? Why are we having more pain with our cycles? Well, it has to do with a lot of factors, but we have, vascular fragility. We have increased prostaglandin release. There's also autonomic dysfunction. And of course, Dr. Maitland, mast cells, right? Mast cells have estrogen and progesterone receptors. And correct me if I'm wrong, Dr. Maitland, but estrogen is considered the accelerator of degranulation. And progesterone is kind of the brake where it kind of stops things. So you have to find a pretty good balance there. But in your cycle, what's going on? The balance is not quite there, right? The fluctuation is what gives you the cycles. So now, why is this important? You got to recognize the patterns to get your patients the help that they need. So fluctuating hormones are causing the problem. Then what do you think the solution might be? Anybody? Cut down the fluctuation, right? Give yourself some constant, continuous hormone therapy. And I'm not saying EDS overrides this. You have to talk with your gynecologist, your OBGYN. Why are they treating you with hormones? And see what your cyclic symptoms are. Talk to them about it and then work together to find that solution. Progestin options are really great. I'm going to talk about that in a little bit. But I'm going to keep going. Menstrual migraines, one quick thing on that. They occur when your estrogen drops. And so one of the easiest things is if you go on transdermal estrogen, as long as you don't have other contraindications, it gives you a nice steady state of estrogen. And that, my friends, is a really good solution towards menstrual migraines to avoid that deep drop. But again, make sure that is a safe option for you. So I'm going to skip through this one. Pregnancy. We're going to talk a little bit about pregnancy now. My time in gynecology did not really focus on pregnancy, but because of the EDS connection, I definitely wanted to bring that to light in my talk. Pregnancy, normal pregnancy, with or without a connective tissue issue, requires ligament relaxation, cervical remodeling, right? Because the cervix, which is the canal, which is long and tight, narrow, keeps everything up where it should be. But when it's time for delivery, the cervix shortens and dilates, right? So that's hormones at work here. And of course, vascular adaptation, because what happens during pregnancy, your blood volume decreases or increases quite a bit, right? So now, again, in EDS, what's going to happen is these normal processes that you undergo are going to be exaggerated. It's going to lead to increased pain, instability, and dysfunction. And I'll tell you, during my first pregnancy, I didn't know I was hypermobile. Everybody just called me Gumby Girl growing up, and I just thought it was pretty normal. So, but I did pretty good. I only had one support belt. And then by pregnancy 2, there was no pelvic floor left. And so my support belt had 3 pieces to it plus suspenders. So, and pelvic floor therapy came into play there. So our study and pregnancy outcomes, interesting, term delivery and cesarean rates were comparable in our groups. However, the hEDS group and the HSD group definitely had more prenatal complications. Now, this includes, of course, worsening joint pain, instability during pregnancy. It can be, actually, those two are more common in HSD, pelvic girdle pain, musculoskeletal pain, dysautonomia, POTS symptom exacerbation, fatigue, functional decline. There was a higher miscarriage rate also noted with HSD. Now, increased reports of preterm labor have also been noted. I think part of that's the cervical incompetence and also the connective tissue issue between the placenta and the connection with the uterus, premature rupture of membranes, and of course, prenatal bleeding and hemorrhage, antenatal. So rapid or precipitous labor and bleeding concerns. All this needs to be taken into account. Now, our findings do show that pregnancies can be successful, but there's often a high symptom burden. So what we need to do is make sure that you have a plan, that you're talking to your OBs, you're talking to your high-risk groups if you need it. So preconception planning, which should start before pregnancy, should definitely include subtyping, because subtype matters on your risk profile during pregnancy. Your musculoskeletal system should be assessed for a baseline. Start the pelvic floor physical therapy, get your pelvis primed and ready. Review the medications, obviously, to make sure there's nothing that could harm a potential fetus and cause risk to your pregnancy. And of course, have that difficult conversation about inheritance and risk to your future generations. Now, during pregnancy, cervix should be monitored for insufficiency. I think that's key, because if you have cervical insufficiency where things are starting to shorten and dilate, you got to get something, you got to get something happening to help you there. And what's common is what's called a cerclage, where they stitch the cervical neck, the canal, depending on what type of stitching is used, to buy you some more time. And it may also require bed rest. So just a quick story. My mom, who is hypermobile but refuses to believe it, has had 5 miscarriages, all due to cervical incompetence, late 4th month, early 5th month. And I'm the only one that survived in her pregnancies because she got the cerclage. And even with the cerclage and bed rest, I was still born at 28 weeks in India. So there's an interesting story there. Now, during labor and delivery, what's really important is individualizing the birth plan. I probably wouldn't recommend a home birth. I don't know. Neuroaxial anesthesia is generally considered safe in hEDS. And of course, positioning, very, very important, because you do not want something subluxing, dislocating during your delivery. So cushioning, stirrups, make sure that they're taking all that into account. And maybe C-section is a little bit better for you. The other thing is anticipate fast labor and hemorrhage. My second delivery, of course, I had no pelvic floor to support anything, but my first delivery took 3 hours of labor plus vacuum suction to get that kid out. Second delivery, the nurse is like, you need to stop pushing because the baby's going to pop out. And the doctor's in the emergency room with another patient. And I was like, I don't think I can stop the baby from coming. So now, after delivery, extended wound care monitoring is very important. If you had an episiotomy, if you had any stitches put in there, give it some extra time. They say, hey, you're clear, 6 weeks, go have intercourse. Maybe not so much, okay? Your partners aren't going to be happy with that, but I think, caution is better. Pelvic floor rehabilitation, that is probably the main thing that got me back on my feet after my second delivery. And I am a strong supporter of that. And I think there's a few pelvic floor physical therapists here. Yeah, kudos to you, thank you. Yeah. And of course, postpartum depression and PTSD. I think overall, with the medical trauma we face, the health issues, the challenges, not getting the help we need, and then you're put into this sort of situation, and guess what? We are at a bit more risk for mood symptoms and postpartum issues. So make sure that you get the help that you need. Now, EDS subtypes. The good news here is hypermobile EDS and HSD, you're pretty good. You're going to have generally favorable pregnancy outcomes, maybe some increased pain and stability. Dysautonomia may kind of get riled up a little bit, and some prenatal complications, maybe some mast cell activity, hyperactivity. Classical EDS, we got a little more stretch, right? So increased tissue fragility puts you at higher risk. You're at higher risk for perineal trauma, poor wound healing for sure, and healing and hemorrhage risk. Now, the big one, the big guns, is vascular EDS. That has the highest maternal risk as far as I'm concerned, high morbidity and mortality. And I think there is about a 5.7 risk of maternal mortality when you have vascular EDS with pregnancy. And interesting, about 13% of women don't even know they have vascular EDS and are pregnant. So think about that, right? Now, vascular EDS, can you be pregnant? Sure, but you got to be very thoughtful about this. You got to discuss the risks, have that conversation with your partner, have that conversation with your providers. There's such a high risk of arterial rupture and uterine rupture, again, maternal mortality, and you have to be established with a high risk group to get the care that you need and the surveillance that you need. Now, sexual health in HEDS and HSD. So this is a little bit of our study findings, and there's no surprise here because, you know, there's things like pain with intercourse, dyspareunia that kind of comes into play, and pelvic floor dysfunction comes into play, and sometimes we're just too tired. So our findings show that dyspareunia, which is pain during or intercourse, HEDS was 46% compared to 32%. And that's pretty significant. There was another study that showed with women with dyspareunia, I think the result was about 48% had reported it. 8% avoided intercourse completely. So, okay, I got to talk faster. So, libido is definitely affected because guess what? If you're having pain with intercourse, your brain, which is your biggest sexual organ, is going to shut that libido down in an attempt to protect you. Why would it let you do something that's causing you pain? And of course, orgasmic ability. And that kind of goes back to a little bit to blood flow. It goes back to dysautonomia. It goes back to pelvic floor dysfunction, things like that. So now this is a sad, sad statistic. And I actually am super sad to discuss it, but I think it's very important what our study found. Abuse history is so prevalent. It's a sobering finding from our study. Nearly half of the females with HEDS and HSD reported prior abuse, significantly higher than the controls. Emotional and verbal abuse were most common, and females with HEDS also reported higher rates of sexual abuse. Abuse history has very important implications for chronic pain, sexual dysfunction, anxiety, and PTSD. These findings do not imply causation. They do not suggest the abuse explains or causes EDS or hypermobility related symptoms. Rather, abuse history represents a contextual factor that can influence pain processing and nervous system regulation, sexual health, anxiety, and quality of life. So clinically, this again reinforces the need for what? Sensitive screening, trauma-informed care. And I'm going to tell you right now, most patients aren't going to come forward and say, I have a history of abuse. So the providers here, you have to make that effort in a very sensitive manner to bring this up. And, you know, maybe it takes a little bit more education on how to do that thoughtfully and sensitively. So I think I had a theory on this, why we are probably more prone to abuse history is that we go through life with a lot of people not listening to us, right? We get gaslit. And then the first person who might show us some attention, good, bad, ugly, right? We kind of gravitate towards them. And then, yeah, we're vulnerable. So now, sexual dysfunction, again, pelvic floor dysfunction, tissue fragility and pain, fatigue, autonomic dysfunction, all of that comes into play. It's important to understand that the biological and biomechanical factors that affect sexual function, because this will shift our focus and our blame away from the patient. It's not a psychological thing only, right? Our psyche does get affected by everything we go through, but we don't want to put blame on the patients, and we definitely want to get them the help that they need. Now, how do you do this? Well, you got to ask the questions. You have to have those conversations. You have to ask about sexual health directly. You have to screen with sensitivity for abuse history, and of course, refer. And I think for me, pelvic floor physical therapy and behavioral health are my two go-tos for sure. So pelvic floor and genitourinary conditions. Also, some interesting statistics here. HEDS had 24% that reported pelvic floor dysfunction, hypermobility spectrum disorder, 19%. And as you go through this, prolapse was also more common in HEDS, bladder prolapse, rectal prolapse, uterine prolapse. And what does that tell us maybe? Even though things are on a spectrum, that tells me basically that HEDS has more of a connective tissue issue going on here. And that's why we're having more of these issues. Okay, I'm going to skip UTIs. Menopause. So biggest hormone shifts are occurring with menopause, right? You have estrogen declining, progesterone declining, loss of the connective tissue support and repair signaling is traumatized too with this. increased collagen degradation. You're getting slower turnover on the collagen, and the collagen that's being built is not going to be as good as it should. So that's why women, how many of you are experiencing perimenopause or menopause and feel like your symptoms, got hit by a Mack truck? Okay, yeah. So again, here, menopause hormone therapy can be extremely helpful, but you got to make sure that it's safe for you, that it's not going to increase your risks, breast cancer risk, things like that. If you have a seizure history, blood clot history, systemic estrogen may not be your obvious option, and you have to tread lightly. Transdermal estrogen is the best choice. Patches, again, is what I start with in my menopause clinic because it gives you a steady state of estrogen. It avoids being metabolized in the liver for first pass effect. And first pass effect is where, if you take an estrogen pill, that is where your blood clot risk goes up because your liver is busy now, dealing with the oral estrogen instead of working on your coagulation factors. So again, I'm super simplifying that. So now transdermal estrogen, they're going to say, Shilpa, I can't do Band-Aids. I can't do adhesives. You're leading me down the wrong road here. Well, there are other transdermal options. So there's a daily gel called, I don't know if I can say the term, but there's a daily gel that you rub into your anterior thigh. There is a spray also that you can use. So there are other options, and there's even a vaginal ring that'll release estrogen. So, and of course, progesterone, the only role is going to be endometrial protection overall. So if you don't have a uterus, you don't necessarily need to be balancing the estrogen with progesterone because that will infer a higher breast cancer risk in itself. But there are other indications for progesterone, but I can't really go through that right now. So again, this is kind of, we know this. We all need multiple providers. We need multidisciplinary management. When it comes to gynecology, you're going to start with your quarterback. The primary care internal medicine team is going to be very important because they're coordinating, they're screening. They are your first line of defense and offense. Gynecology for your menstrual symptoms, contraception, menopause, urogynecology, right? Usually a gynecologist or a urologist who's completed their basic residencies and then gone on to do 3 extra years of fellowship training. Pelvic floor physical therapy, pain management, behavioral health, trauma-informed care, right? Genetics, again, for family planning and confirmation of your subtype. And again, additional specialists as needed. So I'm not going to have time, I think, to go. Time's up. All right, so my clinical pearls here, feel free to take a picture of this. Providers can use this, and I think if you just flip the script a little bit, you'll be able to use this as patients. Got it? Okay, to go to the next one. Take-home points. hEDS and HSD are associated with substantial gynecologic and reproductive symptom burden. Hormones modify connective tissue behavior and symptom severity across a lifespan. Menstruation, we got puberty, menstruation, we got pregnancies, peri and postmenopause. Pregnancy outcomes are favorable, usually in hEDS and HSD, but carry increased morbidity, not mortality like in vascular EDS. And vascular EDS definitely requires distinct counseling and risk management, high risk management. Multidisciplinary symptom-driven care will definitely improve quality of life. And I definitely want to thank the University of Virginia for inviting me to speak here. Definitely want to thank my mentor, Dr. Knight, and of course, our wonderful EDS team at Mayo Clinic, and all the patients who have helped us, participated in our research, have been on our advisory board. And in case Dr. Knight has forgotten what Florida is really like. So.
Despite getting rushed along, we do have time for questions. So, yeah, lots of questions. Wow. Okay, where should we begin? Yeah.
So I am a public learning therapist as well as a therapist. So I see a lot of mix, but there's a lot of beginning research coming out on pregnancy and where the passage during pregnancy to prevent prolapse or at least help support. Are you seeing any of that in the clinic or in research, or would it be more helpful as a protective mechanism for our hypermobile?
I'll be quite honest, we do not have OB at Mayo Clinic, so I have not come across those patients. But we do know that in non-pregnant patients, just pessary use in itself, it's not just the scaffolding that's holding up the prolapse, giving you function and anatomy back, but as you know, it's also going to help the pelvic floor muscles kind of increase, probably not going to use the right word, but the strength of the tissues and the bulk of the muscles down there. So could it be a good adjunct? Yeah. I would be careful about the risk of infection though. So, yeah.
We have another, yeah, go ahead.
No.
I am on my third pregnancy, and I've experienced various different pregnancies. Lactate has influenced each one. But I've also gone down the rabbit hole trying to look an expert on pregnancy and hypermobility, and a lot of them just say it sucks, you're going to be in pain, and just get through it because you're used to pain, whatever. Anyway, I'm wondering if you've seen any connection between diet, specifically glucose management, maybe NPAX management as well, and that improving lactate symptoms in pregnancy. And then the next question is a little bit more esoteric. Is there any evidence that managing lactate within pregnancy can decrease the risk of level of lactate of your offspring?
Can managing laxity during pregnancy decrease risk of laxity in the offspring? I'm going to say no, unfortunately, because where's the error? It's in our blueprint, right? It's the base, the genetics. So no, the dietary question is interesting. I think, of course, during pregnancy, you're going to optimize your diet, right? You're going to eat healthy. But what's the overriding thing? The phenotypic modifier. It's the hormones, and the hormones are at the highest, level, right? So I don't think you can quite override that with any sort of specific dietary interventions. But of course, I'm going to say yes, avoiding, say, dietary triggers that are going to stimulate any mast cell activity symptoms, that would be wise. So, yeah.
Another question, Alan. Yeah.
Could you say something
So, thank you for that curveball. Can we throw them out now? So, yeah. What's yeah. Yeah.
I hope everyone can hear me. I don't think it's appropriate premenopausal, but postmenopausal, I think it's particularly helpful and important.
Now,
Thanks for bringing it up.
I'll actually go off the beaten path here a little bit and agree in general, but in my menopause clinic, we actually are very strict and follow the Menopause Society's guidelines. And so for testosterone therapy, I get women who come in and said, I'm gaining weight, I have no energy, I need testosterone. And the answer then is no, okay, because that's not an appropriate indication for it. Our Menopause Society guidelines say it is for hyposexual disorder, it's for things like that. And now, off-label use, in our population, like I said, I'm willing to try a lot of things. So, yeah.
We have time for one last question. Oh my gosh, you're definitely going to have some questions during the break, Shilpa. Yeah, the back there.
So one of the things, thinking about the talk from today, yesterday, working in the menopause area, thinking about the studies that are showing that people are having longer menopause with more severe symptoms. From the gynecology research, we've been thinking about Dr. Maitland's discussion about environmental changes, things like that. And then some patients also aren't getting full relief from just the hormone replacement, even a strong acupuncture style. So is it worth thinking about the menopause getting worse and more prolonged? Patients who aren't responding to just therapy should also be screening for probably most likely historical hypermobility at that point, but then also considering dysautonomia as a secondary factor for continued hot flashes and palpitations.
I don't think I can repeat that.
So is menopause is worse for patients with EDS?
I'm going to say yes, because remember, hormones are going to, whether it's whatever fluctuations in hormones are going to exacerbate our pre-existing baseline connective tissue issue. Is EDS causing a longer menopause? Not necessarily. Everybody's journey is going to be different. You know, I always get asked, hey, how long is this perimenopause crap going to last? And I'm like, if I knew that answer, I'd be rich. And there's no way to say. Now, if you have an older sister, if your mom went through menopause, you can kind of go by what they went through to kind of predict what you might go through. I'm not sure if I'm answering your question, though.
Talked to my grandma, she like barely remembers menopause. Then talked to my mom, like it's bad, and I'm like over here.
Yeah.
There's been a shift in the duration of perimenopause. Could that potentially be related to what Dr. Abram was talking about the environment changing?
Yeah, we have a lot of what we call xenoestrogens in the environment now that are definitely changing things. And fertility rates, for instance, are going up. And mast cell definitely plays a role, right, in ovarian function. And we know that COVID, for instance, can definitely cause dysregulation in the menstrual cycle. And it functions almost in a similar way as the pathways that, you know, mast cells hyperactivity can too. We're not sure, like, you know, why, for instance, with COVID, somebody ends up in the ICU while somebody else says, oh, I had a mild cold, flu-like symptoms. Well, it depends on which pathways are being triggered, right? So if you have an excessive trigger and multiple pathways being, you know, activated, you might have extremely severe symptoms. Whereas if you're not, then you're gonna be like, I had a flu. So.
I'm just thinking about the patients who come in and they're on like max dose estrogen and they're like, I'm still not feeling well.
So when you say max dose, are we talking oral? Are we talking transdermal? What are we talking? All right. So if I have a patient that I started on transdermal therapy and they say 2 months, they'll send me a message, Shilp, I don't think this is working. My symptoms are just kind of the same. So I'll be, all right, let's get an estradiol level. So for instance, if somebody's on a 0.1 patch, their level should be plus or minus 100, estradiol up 2. So if I check that level and it's like 30, 60, 70, even 80, I'm be like, you know what? I don't think you're necessarily absorbing the patch estrogen or you're not metabolizing it that well. So then we change formulations and we see if we get better results. So, and sometimes, you know, depending on age, if it's early menopause, premature menopause, that's going to affect the dosing, right? Because we do know that, you know, the average age of menopause in the US is 51, 52, but if you lose your ovarian function prior to that for whatever reason, surgical menopause or other, then you do need to be on some sort of replacement. There's no obvious contraindication because you're going to affect your cognitive health, your cardiac health, as well as, you know, bone health moving forward. So, yeah.
All right. Thank you.